Hello and welcome back to Diabetic Foot Files. I'm Dr. G, and today we're going to talk about something that I feel makes some people uncomfortable, and I think it possibly even makes the patient biomechanically uncomfortable. And today's episode is Stop Leaving the Fifth Digit. We all love our pinky toe, but before anybody panics, this is not about ego, this is not about blame or surgical shaming. This is all about biomechanics. This is about physics. This is about what actually happens to your foot after a partial amputation. Because I see this all the time. The is gone, the second, third, and fourth digits are gone, and then they left the fifth toe hanging on. And then everybody wonders why the foot is collapsing, an ulcer recurs, the braces are failing, the patient's gait deteriorates, and the patient ends up back in the OR. So today we're going to be talking about why leaving one digit behind is biomechanically dangerous and when to do a full transmetatarsal amputation is actually more the conservative choice, to be honest, if it's needed to be done, and what the science says, what the boards say, to be honest, and how the biomechanics should be corrected after the transmetatarsal amputation, and what the patients must be placed into after the transmetatarsal amputation, such as orthotics, bracing, and beyond. So let's get into it. So before we talk about that, I know there's this myth that says less is more, right? Sometimes, okay? Everything's like a double-edged sword. You got to see both sides, right? But the common belief in surgery, if we could save something, we should. And that I agree. I totally agree with that. And emotionally, that makes sense. But you also have to think about the biomechanics. And, our feet do not work on emotions, okay? It works on balance, force, and lever arms. And saving a piece of a system does not mean you're actually saving the system, okay? Sometimes saving a toe actually destroys the entire foot biomechanics, especially if you already took all of his friends, okay? Because we all have like 5 toes. And there's some people who have more than 5 toes. We'll get into that in a whole different episode, okay? But what do our toes actually do? Our toes are not decorative, okay? Our toes are meant for propulsion, balance, medial, lateral stability, push off, efficiency, and forefoot loading sharing, okay? So the hallux is the big toe. The hallux alone carries up to 80% of the push off force during gait, okay? So that's why your big toe means so much, and that's why it's also one of the most common places for patients to get ulcers on because it takes a lot of pressure. It's very important when it comes to our gait, our walking, our ambulation. The lesser toes, the second, third, fourth, and fifth, are smaller toes. They stabilize the forefoot. They also prevent rotational collapse and they share the pressure across the metatarsal heads. So when you remove the toes, you're not just removing the skin and bone, you're actually removing the vectors of force. So, what is the biomechanical disaster of leaving just the fifth toe behind? So, let's say a patient doesn't have their hallux, their big toe, they don't have their second toe, they don't have their third toe, and they don't have their fourth toe, but you left the fifth toe. The fifth toe still remains. And what happens biomechanically? Okay, we all know that some of the major stabilizers are attached to the fifth digit and along that lateral aspect, right? So the fifth ray becomes the unopposed lateral stabilizer. That means that there is no medial counterbalance, okay? What is the result of that? There's going to be a varus drift. There's going to be something called a supination bias, and there's going to be increased lateral column pressure. Then there's going to be this rotational torque. With the medial toes, right? If the medial digits are gone, the foot rotates around the remaining lateral structures, which causes a fifth metatarsal overload, which causes a lateral plantar ulceration, which causes perineal dominance, and it causes an unstable corkscrewing gait for the patient. Now, when it comes to pressure concentration, instead of distributing the load, right, the pressure funnels into that one metatarsal because you're just leaving one toe now and that one digit, and it becomes a one failure point. So that one fifth digit that you left behind and you already took away all four other toes, that fifth digit becomes a pressure magnet, not a stabilizer. It becomes a pressure magnet. And remember, pressure always wins. So this is why it could lead to a recurrent ulcer. So this is why patients will come back most likely with a chronic fifth med head ulcer or recurrent lateral wounds on that side, skin breakdown despite great shoes, could have bracing failure, and also the wound is not the problem at this moment. It's actually the architecture of the foot at the moment. And you can't really orthotic your way out of this mechanically unsound of the foot biomechanics at the moment. So what really happens? So let's go a little bit deeper about when you're leaving just the fifth digit after losing your digits 1 through 4, okay? It does create a biomechanical chaos, but we're going to deep dive into it, okay? So the fifth digit, we already know, controlled by tendon, muscles, and force powers, okay? And what happens is they're going to reroute, they're going to overpower, and they're going to destabilize the foot, okay? And what actually happens to the muscles when you leave the pinky toe versus what to do when you perform a balanced transmetatarsal amputation. That's kind of what I see somebody removing digits 1 through 4 and leaving the fifth versus removing all the digits. I see it as an unbalanced transmetatarsal amputation because there's no reason to really leave the fifth digit, to be honest. I understand we want to keep as many toes, but it actually causes a little bit more harm than good because it makes the foot very biomechanically unstable. So, like we said, the foot is a force system, not just a structure. So, every muscle in the foot that exists is to balance another muscle in the foot to counter the force and to stabilize the phase of gait that the patient is. And anybody, I know a lot of people don't know, but there are actual phases of gait. There are actual phases that your feet go into. There's like swing phase, stance phase, things like that. Okay, but that's biomechanics of ambulation, of walking. But when you remove digits asymmetrically, okay, the muscles lose their opposition and the unopposed muscles will always dominate. So those muscles along that fifth toe are going to be dominating that foot, okay? And that dominance creates deformity, pressure, ulceration, and gait failure. So let's go deeper into the muscles when it comes to the fifth digit. The peroneus longus. I love me a peroneus longus, not gonna lie. So the peroneus longus, what does it do? It plantar flexes the first ray, stabilizes the lateral column, and balances the tibialis posterior and the tibialis anterior. When the medial digits are gone and you left the fifth digit, the peroneus longus becomes overdominant. It pulls the foot into a plantar flexion eversion. It drives lateral column overload and increases the pressure at that fifth metatarsal base and head. And what would the result be? The result will be a lateral plantar ulcer, a cuboid stress along that area, and then instability during mid-stance phase of ambulation. Then the flexor digitorum longus and the flexor digitorum brevis. The flexor digitorum longus and brevis, normal function is to flex the lesser toes and to stabilize the forefoot during propulsion, okay? When those are missing, when the toes are missing, the tendon loses its insertion targets, okay? And the contracture forces redistribute abnormally. And the remaining digit, the one pinky toe, becomes a pressure anchor, pretty much. And so what will that result in? Digital clawing, you'll notice that. And there'll be an increased plantar pressure beneath that remaining pinky toe. And then there are going to be a non-functional muscle force going on. Now, next muscle, the extensor digitorum longus. Extensor digitorum longus, that's at the top of the foot, okay? The normal function of that is to extend the lesser toes. It also assists in ankle dorsiflexion and helps control the swing phase of gait. After partial digit amputations, it loses distal mechanical advantage. It becomes inefficient, the extensor digitorum longus, and it creates imbalance with the flexors. So that result will be dorsal instability. The swing phase of that patient will be altered, and it increases the chances of the patient tripping. Now, some of the big players. Tibialis anterior. What is the normal function of that? Primary dorsiflexor of the foot, okay? It controls the foot placement and it prevents what we call foot slap, okay? After asymmetrical forefoot loss, right? Let's say you're moving all the toes and leaving just a pinky, it pulls the foot into a dorsiflexion inversion. So there's no medial forefoot to stabilize against that. And that causes what we call a varus bias. And I know biomechanics is a whole different language. Biomechanics is pretty much the physics, okay? Physics of the foot, of the lower extremity or any part of your body, but it's the physics of it, okay? And what that is going to result in when you lose the normal function of your tibialis anterior secondary to removing the digits, you're going to have something called a supinated gait, lateral instability, and increased lateral plantar pressure. So if you haven't noticed, there's a common theme that there's going to be increased pressure on that lateral side where you left the fifth pinky toe. Now, our big baller, shock collar, our Achilles heel. This one is critical. Like I always say, if you're doing a TMA, you gotta do a TAL. TMA, TAL. Okay? So, transmetatarsal amputation, the adjunctive procedure for that you should be doing at that exact same time while the patient's in the OR, you need to do a tendon Achilles lengthening procedure, okay? Which can be done percutaneously. So the Achilles tendon, our big baller. So the normal function of the Achilles tendon is the primary plantar flexor. It controls the push off and it helps balance the tibialis anterior. When there is a partial forefoot amputation, the Achilles tendon becomes functionally too strong and it's no longer a forefoot lever arm and push off happens prematurely. And what's the result of that? What happens is the foot will become more in equinus tendency. There's going to be increased in forefoot pressure and recurrent ulceration. So when a patient has a TMA, a transmetatarsal amputation, or amputation of all the digits of the foot, and they did not do a TAL, a tendon Achilles lengthening procedure, and the notice that the patient is having ulcer on the plantar aspect, the plantar distal aspect, is because they did not do a tendon Achilles lengthening and the foot is in equinus, in a very rigid equinus right now, okay? Because you need to increase the range of motion of the Achilles now because it is too strong, okay? This is why the Achilles lengthening procedure is often an adjunctive procedure of the TMA. So like I said, if you don't remember anything, TMA equals TAL, okay? Sounds good. Or any forefoot amputations, to be honest, that have recurrent ulcerations along the plantar. Yes, you have to think about equinus. I don't think people realize how powerful equinus is, but yeah. Next is our flexor hallucis longus. Our flexor hallucis longus tendon, it actually stabilizes the medial column, drives push off, and controls balance. If the hallux is gone, the big toe, the flexor hallucis longus loses function. It becomes a vestigial muscle, and there is no meaningful contribution to gait anymore from that muscle. Okay? So that means the result will be loss of medial propulsion, increased lateral compensation, and energy inefficiency. So, why does doing a full TMA instead of just leaving at the fifth toe restores the muscle balance? So, when done properly, TMA removes the asymmetry, okay? And it eliminates the rogue force vectors and creates a balanced distant lever arm for the patient. So the muscles now pull against a uniform platform and can be accommodated also with orthotics and bracing, and it stops competing with each other destructively. So the key principle is muscles don't need your toes. Muscles need balance, okay? So post TMA biomechanical management to control the muscle dominance after a transmetatarsal amputation. Biggest thing, Achilles management. So they're going to need physical therapy, stretching, serial casting, lengthening when indicated. Next is orthotic control. So you might need a total contact insert. You might need a forefoot fuller. Most likely you will. You might need a rocker sole. AFO wise, when needed, you will need an AFO that controls the equinus and helps stabilize the mid stance of the patient's gait and improve the stability. So, when a full TMA is the better option, is when it can be more limb salvage than doing a partial one. Okay, so think about that. So, when they're removing, say they have to remove 3 toes, right? And only 3 toes, if it's 3 or more toes, you should do a full TMA. Even if the 5th toe is good, you should do a full TMA because the patient's gonna end up in the OR, unfortunately, due to biomechanical imbalance and a recurrent ulcer along that 5th toe to be a pressure point, okay? So when 3 or more digits are non-viable, a full TMA is often done due to restore symmetry, y'all gotta forgive me. Symmetry creates a balanced forefoot platform, improves the bracing fitting, reduces the focal pressure points, and improves the energy efficiency in the gait. So a partial asymmetrical forefoot, that's going to create chaos, okay? So a TMA, like removing 4 digits with and leaving the 5th pinky toe is pretty much an uncompleted TMA, asymmetrical TMA, okay? And a well-balanced TMA creates predictability, okay? And that helps better when it comes to healing, okay? Whenever studies have shown consistently that partial forefoot amputations have higher risk of reulceration. Asymmetrical forefoot remnants increases plantar pressure. Okay. And when done properly, a TMA done properly, it can improve the patient's gait efficiency compared to just having serial digital loss. So, biomechanically, what can we do when the TMA is done fully healed? Because the TMA is not the end of the treatment. Now we have to what I call biomechanically reconstruct the patient's foot fully when it comes to what they should put as a shoe gear. So, certain accommodative orthotics, like a rocker bottom, a toe filler, toe fillers help prevent pistoning, reduce shear. It helps improve the stand space for the patient. Like we said, the ankle foot orthosis it helps especially when there is equinus present, if there is calf dominance, and helps balance anything that is impaired. And then the rocker sole footwear that helps restore forward progression and reduce forefoot stress. So what else can we use? Like I said, the TAL, gait training, it's really good for the patient to have physical therapy, regular pressure map it in your head, ongoing skin surveillance of the area of that TMA, and team-based follow-ups, okay? Remember, it's a multidisciplinary approach when it comes to everything. Just doing surgery is not the end of it, okay? It's a long-term biomechanical partnership with your patient now, especially when you remove part of their digit or limb, anything, okay? So saving a toe is not the same as saving a foot. So leaving the 5th digit when the rest are gone is not actually conservative. It's actually more destructive. So true limb salvage is not about what you leave behind. It's about what the foot can do afterwards. Is the foot more stable? Is the foot more balanced? Can the foot function properly? Does the foot have stability? These are all the goals for the patient. Does it increase the patient quality of life? So let's go through some quick high yield board questions just to get that over and done with so somebody can learn something. So what muscles become over dominant when the medial digits are lost, but you left the 5th toe? It's going to be peroneus longus. I'm not going to go through the multiple choice. Why does equinus commonly develop after a partial forefoot amputation? Because there's nothing to unoppose the Achilles tendon action. Which structures contribute the most to lateral plantar ulceration after leaving the fifth digit, peroneus longus? Why is a full TMA biomechanically superior compared to serial digital amputation? Because a full TMA creates a symmetrical force distribution. Loss of the hallux, aka the big toe, primarily eliminates the function of what? Medial propulsion and push off. Next question. I'll try to do 10. If I do more, I'm sorry. After the loss of the hallux and the central digits, with preservation of the fifth toe, which gait abnormality is most likely? Now I'm going to do some multiple choice. Is it A, excessive pronation during mid-stance phase? Is it B, varus and supination bias during push-off? Is it C, increased medial column loading? Or is it D, delayed heel rise? The answer is B. It's going to create a varus and supination bias during push-off. So when you leave just a pinky toe, just think supination and varus, okay? There's not going to be any valgus, okay? Just varus. Varus and supination. So the loss of the medial forefoot removes the counterbalance and the lateral structures dominate. So that will create a varus and a supination. It makes sense once you know where the muscles are. Now, when the tendon loses, which tendon loses its most functional role after hallux amputation? Is it A, the tibialis anterior, B, the peroneus longus, C, the flexor hallucis longus, or D, the Achilles tendon? The answer is going to be C, the flexor hallucis longus. The flexor hallucis longus insertion and propulsion role, once the hallux is absent, it's completely gone. It's kind of useless right then, okay, once the hallux is gone. Next, a patient with a partial forefoot amputation develops a recurrent lateral plantar ulcer. Which muscle is imbalanced and is the primary driver? Is it A, overactive tibialis anterior? Is it B, a weak tibialis posterior? Is it C, a dominant peroneus longus? Or D, a plantar fascial contracture? Is C, a dominant peroneus longus? If you go through this with anatomy, you'll understand why it's peroneus, okay? Lateral is peroneus, okay? And then medial side is tibial. Why does Achilles tendon lengthening reduce recurrent ulcerations after TMA? Is it A, that it improves venous return? Is it B, it enhances proprioception? Is it C, it reduces plantar forefoot pressure? Or D, it increases push-off strain? It is C, it reduces forefoot plantar pressure. Next, which stage or which phase of gait is most interrupted after having an asymmetrical forefoot amputation? Is it A, initial contact, B, the loading response, C, the terminal stance and push off, or D, the swing phase? It is C, the terminal stance and push off. I guess we can go into all of these later. I have like 10 more, but I hope this episode was a good takeaway for patients. So this is Diabetic Foot Files, where we don't just save limbs, we help restore function, dignity, and movement of the patient. And if this episode made you think differently, hopefully it did. You can share it, because sometimes the hardest truth is the ones that help save the feet the most. So leaving the fifth toe, yes, you're going to preserve the anatomy, but it destroys the mechanics of the patient. Balanced TMA removes the anatomy, yes, but it restores the function of the patient. And limb salvage, like I said, is not just about how much you save, it's about how well the foot still works afterwards and the quality of the patient life. So this is Diabetic Foot Files with Dr. G, and take care of your feet because they take care of you.